Good day, everyone. Thank you for joining us for this special session on CTO PCI. My name is Byeong-Keuk, and I am honored to co-moderate today's discussion alongside with Dr. Scott Harding. In this session, we have the privilege of speaking with several distinguished experts in CTO PCI from around the world. Let's begin by hearing some insight on the recent advancement in CTO procedures across different countries and different committees. So in your opinion, so what have been the most significant recent changes from Werner? Okay.
Well, I think we have more operators now than maybe 5 to 10 years ago on a high expert level, which is reflected also by the membership of the European CTO registry. But we were a little bit behind in technical developments because many of the devices that are already on the Asian market or US market have only recently arrived. In Europe, we are a little bit behind on the technical field, but I think the expertise has increased considerably over the last years.
What about the US?
I agree with Gerald, actually. I think that we have more operators, we have formal paths and established pathways as how to treat CTO operators. And if I may say, I know this is a CTO wrap-up interview, but we're talking about complex PCI. So what I tell my fellows or other colleagues is that even if that vessel was not a CTO, it would still be difficult to treat. So you need to be facile with bifurcations. I recently reviewed a paper from Euro CTO about bifurcations at the distal cap or calcification and so on and so forth. So I think that we have more operators. We just need to get some more studies and some more data.
What about the Japan? So usually it's the all new or some advanced technique or some technology came from the Japan. So what about Japan?
In Japan, we can use anti-wall IBUS. Anti-wall IBUS is a special IBUS for CTO PCI, shorter chip and superior trackability. So, and it can make IBUS guide procedure easier. And in addition, we can use a Conquest Pro ST. ST has a sharpened chip and superior penetration holes. So, in use of anti-wall IBUS and Conquest Pro ST, we can use chip detection ADR. So, and before introduction of anti-wall IBUS, in my case, and ratio of anti-grade approach and retrograde approach is 50-50. But after introduction of anti-wall IBUS, ratio is 70-30. And ratio of anti-grade approach is getting higher. Yeah.
What about the complication rate? Is getting lower?
Yes,
It's a change of the approach.
Yes.
So Dimitri, I might ask you a question if you don't mind.
I do, but just for you.
Okay. What do you think the most critical factors are in achieving successful CTO wiring?
Actually, I think this is probably the most important question in CTO PCI and in complex PCI. I strongly believe that we need to train our fellows to understand the engineering properties of the wire. When we are through fellowship, we learn by osmosis. We use the wire that our attending uses, we put the bend that the attending uses without trying to figure out exactly what we're trying to accomplish. So understanding the critical engineering properties of the wire is key because, as you all know, not every wire behaves the same way or takes the same curves and so on and so forth. Then actually putting your own curve. Except for the Gaia wires or the Suo pre-shaped, if someone comes in my lab with a pre-shaped wire, I just kick them out of the lab. They have no business in doing cases. And then I think it's important to get both tactile feedback but also visual feedback about the wire. So wiring is the most complex skill that we have in interventional cardiology, and unless you understand, and I repeat myself, with the engineering properties of the wire, the appropriate bends for the specific task, changing the wire based on the needs, and then having tactile and visual feedback, I don't think that you will be ever successful and safe as well.
Okay, Dr. Hamazaki, so even after successful wirings, there are some cases where we face the uncrossable regions. So what technique or tools do you use to overcome this kind of situation?
Yeah. First of all, we have to perform CTO PCI under best condition. Best condition means we have to use ideal guiding catheter or the strongest backup support. If it is not enough, we have to perform anchor balloon technique or use of guide extension. And however, even if under best condition, it happens. So, and first option is I often use Tornus. Tornus is a special microcatheter, metal chip and metal shaft and screw effect. So it can work well in such a situation. Next option is plug cracking technique with dual lumen catheter and CTO PCI wire. And first, dual lumen catheter is inserted, and CTO wire such as Conquest Pro or Miracle 12 is inserted through the OTW lumen of dual lumen catheter. After that, guide wire is smashed against a plug. It is a very effective. And the next step is, of course, bare wiring with rotor wire. As you know, new rotor wire is a very good quality. So, and region is short and not tortuous. Bare wire of rotor wire is very effective. And in retrograde approach, intentional subintimal wiring is one option. As you know, guide wire device crossing through the subintimal space is very easy. So after that, we can perform reverse cut technique at the subintimal space. Yes.
So Gerald, I'd like to ask you a question. So planning is essential to successful CTO. So how do you go about, what methods do you use to plan for a CTO?
Well, first of all, of course, we have the angio, which is the tool to decide whether we anticipate complexity during the procedure. And the ideal planning tool, of course, is a CT, high-quality CT imaging, which is unfortunately in most European countries not supported by the insurance, but we have to invest into the success of the procedure. So some of these patients, which complexity expected, will be admitted to our hospital one day earlier, and then we perform CT. I look forward to the photon CT because in the future development, bringing it together with co-registration, I see a very high potential, especially in the complex cases. And just one other remark is, for successful procedure, I must be convinced that the procedure is good for the patient. So I talk to each patient before the procedure, ideally the day before, to make myself committed to the procedure, that he is really symptomatic, to also use the procedure to his benefit.
I think that's a very important point, as is allowing dedicated time in your cath lab, because if you're trying to do this in a busy list where you've got competing strategies, that sometimes can get in the way.
Actually, Scott, I'm spending so much time with the patients. I actually bring the computer in and I show them the films. Every single patient, whether it's a CTO or a non-CTO complex PCI, I bring in the monitor and I tell them, okay, this is your spine, this is your lung, these are your ribs, this is your diaphragm, this is the artery, whatever is black is blood, that's how it is. And it's extremely important. It's extremely important to spend time with the patient so that they understand what the problem is and what you can do about it and what can go wrong. And as Gerald said, the most important thing in a pre-procedural planning is to make sure that you establish an indication for the procedure. That's number one.
So actually, you all is a CTO expert. So I think you maybe had some met frequently some failed case, and also you are very good success rate. However, sometimes fail. So when you encounter some failed case, how do you decide whether to reattempt the procedure or not? Or do you have some specific criteria or some consideration for this failed case?
That's a very important question. Again, and thank you for your kind words. Again, the first thing is the indication. Is it worth really putting the patient through a second procedure? If any of us fails on this table, that means that the case is difficult, right? And we can get 95, 98% success rate, but when we used to do that back in the day, we saw that there was a signal for increased complications. So I think that your question basically is trying to balance risk and benefit. So if there is a strong indication, and I think that I've done enough to the artery to modify it, or if I've run out of contrast or of radiation or operator fatigue, then, and I think that I have another option on deck, then I will bring the patient back. If I think that I've exhausted all the possibilities, I was not even able to progress through the case and modify the vessel, or if the indication is soft, then I would sway away from it.
What about Gerald's opinion?
Yeah, I agree, actually, especially with the assessment of where are the other options. So actually, to answer this, I looked into last year's data, and there were about of 283 cases that I did personally, 25 that I failed initially, and in 15, I didn't see any option. There was too much calcium, there was no flow. In the other 10, brought the patient back and learned from the first experience. Sometimes you miss a collateral. Sometimes you damage a path right to a foolish wire movement. So all the other 10 were successfully done in the second approach. But that is down to the experience that you have and the options, and also to the limit that you have to put the patient's risk. I think contrast is a severe issue today, but radiation, I disagree, because radiation is, even in European patients which are slightly smaller, but only slightly smaller than the US average, radiation in our system is no issue. We never exceed 2 gray. Because we have excessive radiation management from the first shot.
Yeah, but this, I mean, I have to give credit to Gerald, because you've done some of the initial work and you've been a pioneer about radiation. And not every lab is as astute and careful in tweaking and modifying their equipment. I was once in another country, and they asked me to come in and bail out a case. And the first thing I looked at was at the grays, and there were at 22 grays. So yeah, so what I'm trying, so what I'm trying to say is that, and I did some studies at Columbia with some equipment and so with, but again, you have to be very careful. Call the engineers, work with them. There are a lot of things that they can do to modify the radiation, but. In contrast to Gerald, my experience has been that not every lab is as good as yours. So the message is people and operators and cath lab managers, they need to actually get their machines optimally tuned.
So related to that, I think, there's been a lot of focus on success in the past, and now we're understanding that safety is equally important as success.
More important, I would say.
I would agree. So what factors what are the main factors you think are important in improving safety in CTO, PCI? Maybe Hamazaki?
Yes.
This is a very difficult question. And of course, prevention is best treatment. However, and we cannot prevent complication completely. So, and we have to think about not only PCI procedure, but also complication at each steps. So, and we have to prepare to respond quickly if complication occurred. Yeah, that's my idea. Yeah.
Dimitri?
Well, I can tell you that one of the things that I've modified during the past 5 or 6 years is at some point, I was about 60–70% retrograde just because of the cases that were coming to me because of a coronary center. And out of those retrogrades, more than 50 or 60% were epicardial. So I can tell you, if you want a quick answer, that I'm not that quick to go after an epicardial collateral. Obviously, not every epicardial is the same, so that's one thing. The second thing is the use of intravascular imaging, both to guide my puncture of a proximal cap or to size my reverse cart so that I don't blow big balloons and so on and so forth, and also at the end to make sure that I have a good stenting result. So again, I think the use of intravascular imaging, staying away from epicardial collaterals if we can, and then use the simplest approach as a first approach.
Gerald?
I agree with all that has been said. Yeah, and as Yuji mentioned, you need to be prepared for the you want to prevent, avoid, like stay away from risky paths, but have your cath lab be prepared. Don't look where is the pericardial synthesis, the drainage setup, where are the coils? They must be at some point where everybody can find them immediately once you need them. And also, I'm amazed that of course, you never stop learning. So today I saw some preparation of blood with thrombin powder as a tool, which is nice. I use thrombin from the set, from the prepared set, yes. But that's not always available. For example, during Iraq war, suddenly there was no thrombin anymore available in our lab. So we need to have versatile armamentarium, but you must be prepared to have that available.
And actually, if I may add, Gerald makes a very important point that it's not about only the operator. And when he says being prepared, he said essentially the whole cath lab team needs to be prepared, because it's not you that you're going to run suddenly, scrub off and try to find where the pericardiocentesis tray is or where the covered stent is. So running drills, like having, a well-organized code. You know what happens sometimes. If a code goes on, then you have 1,100 people coming in, running like chickens without heads. Nobody's contributing anything, and it's chaos. So you need to train the lab that if something happens, these are the people that are essential. Nobody else comes into the room. You have a crash cart where you have all your equipment there. So that's key. You need to have the cath lab staff involved, because you're going to be as good as your weakest link. And you cannot do these cases unless you have a great cath lab staff, great nurses in the recovery area, great CCUs, good surgeons. So it's a teamwork.
So I'll just make a couple other comments around safety. So some of the things we've done to change things is exactly that. We've run simulation courses called React, where we simulate some of the emergencies that happen in the cath lab with the whole team involved. I think that's really, really important. A safety wire. I didn't used to do that, so in the donor guide, always have a safety wire down. And actually use of protamine, when there's been bleeding, has been very, very helpful. So those are some things that have changed. I guess it looks like we're out of time.
The only thing I want to say about protamine is that it's great as long as the patients have been adequately preloaded with DAPT and all the equipment is out.
Correct.
From the coroners.
Absolutely.
Okay.
So I'm afraid we're out of time, so it's time to wrap up. We've covered a range of topics in CTO PCI. We've heard about the fact that, the equipment, we've got to have the right equipment. We may have the skills. We have to understand that equipment. We have to understand the task, and we have to understand the technology that's going to help us with that task. We've heard about how to deal with some resistant lesions, the plaque cracking, the tornus, the subintimal modification. But also, we've talked about very important planning, informing patients, making sure they're understanding, making sure the indication is right, and some of the things for safety, which is now paramount in CTO PCI. So thank you all to the panel, and we'll wrap up the session.
Thank you.
Thank you.
Thank you.